Today we will discuss Rh incompatibility and HDN. When it is called Rh incompatibility? When it is said to be Rh disease? What does it mean by HDN? Pathogenesis, symptoms, diagnosis, prevention and treatment of Rh hemolytic disease. Let's get started. Here goes story of HDN. In the year 1609, a French midwife observed a twin delivery, where one baby was swollen and died soon after birth. Other baby developed jaundice and died several days later. For next 300 years, similar cases were noted to occur throughout world. In the year 1950, it was found out that all these deaths and complications were due to fetal and neonatal RBCs being attacked and destroyed by mother's antibodies. This condition was termed as HDN or hemolytic disease of newborn. In year 1960, it was discovered that giving certain antibodies to high-risk pregnant women prevents HDN in babies. In year 1970, routine antenatal screening was done to find out at-risk pregnant women who are in need of preventive treatment. Afterwards, incidence of HDN causing fetal and antenatal demise has reduced significantly. Still, 3 to 80 out of every 10,000 newborn are affected per year with hemolytic disease of newborn. What is HDN or hemolytic disease of newborn? It is said to be HDN when IgG antibody produced by mother against corresponding antigen present on fetal RBC crosses and destroys RBC of fetus and newborn. Why HDN occurs? It happens because mother's immune system recognizes certain fetal red cell antigens as foreign, as those antigens are absent in mother, following which mother produces antibodies against it. These are of IgG type, hence can cross placenta easily. They coat fetal RBC and destroy them, causing anemia and jaundice. Thereby, HDN is also called as HDFN or hemolytic disease of fetus and newborn. HDN types. There are two types of HDN based on immune hemolysis. First one is isoimmunization, which is most common type, occurs due to blood group incompatibility between mother and baby. For example, Rh incompatibility, ABO incompatibility, and other minor blood group incompatibility. Other immunological disease can also cause HDN. Example, maternal lupus or SLE, and drug or medication in mother. HDN due to blood group incompatibility. There are more than 50 RBC antigens that may lead to HDN. Most important ones are A antigen, B antigen, RHD antigen, RHC antigen, RHE antigen, Kell antigen, Duffy antigen, etc. Out of all antigen, the one we are most concerned about here is RHD antigen. This antigen is most antigenic out of all and leads to potentially most severe form of HDN. In past, RHD incompatibility used to be one of the major cause of fetal loss, stillbirth and newborn death. Blood groups and types. Before discussing in detail about HDN and Rh disease, let us understand some basic facts about human blood groups and types. ABO typing. Based on presence or absence of A and B antigen on RBC surface, an individual's blood type is divided into 4 different categories: O blood type, A type, B type and AB type. Antigen present on surface of RBC on O type is none, on A type is A antigen, on B type is B antigen, and on AB type is both A and B antigen. Likewise, antibody present in serum on O type is both anti-A and anti-B antibody, on A type is anti-B antibody, on B type is anti-A antibody, and on AB type it is none. So to sum up, antibodies in serum of a person are exactly opposite to that of antigen present on his RBC. For instance, A blood group person has anti-B antibody and B blood group person has anti-A antibody in his serum. Rh typing. Rh system or rhesus system of antigen includes 6 different types of antigens. Capital C, small c, capital D, small d, capital E, small e, out of which capital D is most antigenic and small d is non-antigenic. So excluding small d, there are 5 Rh system of antigens. Capital D, capital C, small c, capital E, small e. Most important out of this is Rhd antigen. A person is called Rh positive or Rh negative based on presence or absence of Rhd antigen on surface of RBC. If a person has D antigen present on RBC, he is Rh positive. And if a person does not have D antigen on RBC, he is Rh negative. Approximately 85% population are Rh positive and only 15% are Rh negative, though this number varies with race. How Rhd antigen was discovered? When rhesus monkey serum was mixed with blood of a human being, it is seen that in some individuals it clotted and in rest it did not. If clot is formed, then that individual is said to be Rh positive. If no clot is formed, then the person is said to be Rh negative. Hence the abbreviation Rh originates from the word rhesus. Human blood group types. Based on ABO and Rh system, human blood group types are divided as following 8 types: A positive, A negative, B positive, B negative, AB positive, AB negative, and O positive, O negative. For instance, if an A blood group person has Rhd antigen, he is said to be A positive, and if he does not have Rhd antigen, he is A negative, and likewise. Rh incompatibility and Rh disease. Presence or absence of Rh antigen does not affect health of an individual, but it is relevant during blood transfusion and during pregnancy. Rh incompatibility. If a pregnant mother is Rh negative and fetus is Rh positive, then it is called Rh incompatibility. What is feto-maternal transfer? Usually maternal and fetal blood circulations are separate. But during certain events, some of the Rh positive fetal red blood cell may gain access to Rh negative maternal circulation through minute breaks in placenta. This is called as feto-maternal transfer. What is Rh disease? Rh negative mother recognizes Rhd antigen as foreign and produces antibody against this. Maternal anti-D antibody is of IgG type and hence it can easily cross placenta. These antibodies then attach to Rh positive fetal RBCs and destroy these, leading to Rh disease. As a consequence of hemolysis, there is anemia or paleness and hyperbilirubinemia. Hence, Rh disease is a type of HDN. Why first Rh positive baby usually is not affected? The process of mother getting exposed to Rh positive fetal RBC is called sensitization. Usually it happens during delivery when placenta separates, following which it takes mothers few days to produce anti-D antibody. That is why first baby usually escapes. Trouble arises in next Rh positive pregnancies. With each subsequent Rh positive fetus, chance of HDN or HDFN increases further. Fun fact. It is observed that as minute as 0.1 ml of feto-maternal transfusion can cause Rh disease. In some special circumstances, first Rh positive baby may also get affected. This happens when prior Rh positive blood transfusion or platelet transfusion in mother, past abortion or miscarriage with Rh positive fetus, procedures like amniocentesis, chorionic villus sampling, cordocentesis, etc., abdominal or pelvic trauma during current pregnancy, APH, antepartum hemorrhage, example, abruptio placenta, placenta previa, etc. Previous ectopic pregnancy, molar pregnancy, blighted ovum, etc. These are also called as potential sensitizing event for Rh disease. How hemolysis occurs in Rh disease? When mother is Rh negative and baby is Rh positive, it is called Rh incompatibility. Here Rh positive fetal RBC enter maternal Rh negative circulation, which is called sensitization. It occurs usually during delivery. B cell and plasma cell of maternal immune system then produces anti-D IgG immunoglobulin. This process is called primary immune response. First baby usually escapes. In second Rh positive pregnancy, maternal anti-D IgG enters placenta and binds to Rh positive fetal RBC and destroy them, causing immune hemolysis. Pathogenesis of Rh disease. Hemolysis of fetal RBC causes increase in unconjugated bilirubin, leading to jaundice and kernicterus. Hemolysis further leads to anemia or pale baby. In case of severe anemia, it causes heart failure. Anemia also leads to tissue hypoxia and impaired liver function. This leads to decrease in serum albumin. Hypoalbuminemia causes generalized edema or anasarca. That is how baby develops hydrops fetalis, which manifests as ascites, pleural effusion, pericardial effusion, etc. These leads to respiratory distress. Severe anemia also stimulates medullary erythropoiesis, which results in increasing erythroblasts in peripheral smear. Severe anemia also causes increase in extramedullary erythropoiesis, which manifest as hepatosplenomegaly. Symptoms and signs of Rh disease. Symptoms of Rh disease may vary from mild to fatal. There are 4 different types of presentation of Rh hemolytic disease. First is hydrops fetalis or erythroblastosis fetalis. Second, icterus gravis neonatorum. Third, bilirubin encephalopathy or kernicterus. Fourth, congenital hemolytic anemia of newborn. Hydrops fetalis is the most severe presentation and congenital hemolytic anemia is the mildest form. Symptoms of hydrops. What is hydrops fetalis? Accumulation of fluid in 2 or more fetal compartments, example ascites, pleural effusion, pericardial effusion, skin edema, etc. Here are features of hydrops fetalis: polyhydramnios or increasing amniotic fluid, generalized swelling or anasarca due to hypoalbuminemia, heart failure, etc. Pale baby because of anemia, abdominal distension resulting from ascites, respiratory distress due to pleural and pericardial effusion, heart failure and enlarged fetal heart, hypotonic or lethargic baby, bleeding spots over skin owing to decreased platelet and deranged coagulation factors, large or pale edematous placenta, metabolic acidosis, birth asphyxia in baby, and in most severe cases, macerated fetus, stillborn, and newborn death. Symptoms of icterus gravis neonatorum. What is icterus gravis neonatorum? When Rh positive baby delivered to a Rh negative mother develops jaundice soon after delivery, it is called as icterus gravis neonatorum. Pathological jaundice and icterus gravis neonatorum. Increase in bilirubin occurs in first 24 hours and sometimes even in first few hours following delivery, which is pathological. Hence, baby starts looking yellow or jaundice since day 1. Why jaundice occurs after delivery and not when baby is inside womb? Inside mother's womb, excess bilirubin produced from hemolysis of RBC is handled by maternal liver. Hence, there is anemia but not much hyperbilirubinemia. Serum bilirubin of fetus is why between 3 to 5 mg per deciliter, that is less than 5 mg per deciliter. After cord is clamped, fetal liver has to deal with excess of bilirubin load for which it is not mature enough. That's why bilirubin level rises soon after birth, that is within next 24 hours after birth. Symptoms of kernicterus. How kernicterus develops. Sometimes unconjugated bilirubin can rise to more than 20 mg per deciliter or is above critical level with respect to baby's gestational age and hours of life, as per Bhutanese nomogram or NICE guideline. Unconjugated bilirubin in excess is toxic and lipid soluble too. It can cross blood-brain barrier and stain basal nuclei of brain, causing permanent neurological damage or kernicterus. Bilirubin encephalopathy acutely presents in a baby as refusal to feed, poor cry or lethargy, opistotonic posturing, stiffening of limbs, retrocolis of neck, and sometimes convulsion. In addition, baby will be icteric in kernicterus up to palm and sole. Later in life, it develops permanent neurological sequelae in form of chorioathetosis, spasticity or muscular rigidity, deafness or hearing loss, ataxia or abnormal movements, mental retardation or low IQ. Symptoms of congenital anemia of newborn. This is the mildest presentation of RH disease. Here there is moderate anemia, but there is no jaundice. This anemia develops slowly over next few weeks and it may persist for up to 6 weeks of life, till all maternal antibodies are exhausted. Hepatosplenomegaly is usually present. Fun fact about RH isoimmunization. RH de-isoimmunization is the most severe form of HDN. Infrequently, RSC isoimmunization may be as severe as RHD disease. In anti-Kell isoimmunization, often anemia is the predominant symptom and not jaundice. Diagnosis of HDN. Antenatal investigations, blood grouping and RH typing, maternal antibody detection or ICT, hemoglobin and hematocrit of fetus, delta optical density of amniotic fluid, high resolution ultrasound, middle cerebral artery Doppler, Betke-Kley-Hoyer test. Postnatal investigations are hemoglobin or hematocrit of baby, peripheral smear, reticulocyte count, ABO-RH typing, serum bilirubin total direct and direct cum test in baby. Blood grouping and RH typing. At earliest antenatal visit, blood group and RH type of mother is determined. If it is RH negative or O blood group, then father's blood group should also be tested. Maternal antibody detection. Maternal IgG anti-D antibody is detected by ICT, that is indirect comb test, in maternal serum at gestational age of 12, 28 and 36 weeks. RS positive antibody titer of more than 1:16 is significant. Further rising in antibody titer is more confirmatory of RH disease. Hemoglobin and hematocrit in fetus. It is estimated directly by percutaneous umbilical fetal blood sampling or chordocentesis. If fetal hematocrit is less than 30%, then intrauterine transfusion of fetus is planned. Delta optical density of amniotic fluid. Unconjugated bilirubin sometimes comes out, stains amniotic fluid yellow, which can be detected by testing delta optical density 450 of amniotic fluid. It is then plotted in Lilly's 3-zone chart. Closer the value to third zone, greater is the risk of hydrops. High resolution USG to detect hydrops. Here are signs of hydrops in ultrasound. Polyhydramnios, increase in placental thickening, skin edema, pleural effusion, pericardial effusion, ascites, etc. Buddha position of fetus with positive halo sign, increased knuckle translucency, scrotal edema, hepatosplenomegaly. Middle cerebral artery Doppler. High velocity flow in middle cerebral artery Doppler in fetal ultrasound is an indirect indicator of fetal anemia. Betke-Kley-Hoyer test. This test detects amount of fetal RBC in maternal blood. Hence, it assesses severity of feto-maternal hemorrhage. For postnatal investigation, 5 ml of cord blood is taken after delivery for sampling, out of which 2 ml is oxalated blood and 3 ml is clotted blood. Oxalated blood is tested for hemoglobin or hematocrit to detect anemia, and peripheral smear to detect erythroblasts and signs of hemolysis. Clotted blood is used for ABO and RH typing, direct comb test, and serum bilirubin total direct in baby. Fun fact: peripheral smear shows spirochetes in ABO hemolytic disease, but spirochetes are absent in RH disease. How to prevent RH disease? RH disease can be prevented by giving RHIG or RH immunoglobulin or RhoGAM timely. What is RhoGAM or RHIG? How is it prepared? A pooled human plasma is taken from a set of D negative people who are exposed to D antigen. Anti-D IgG concentrate extracted from this plasma. This anti-D concentrate is called as RHIG or RhoGAM. Facts about RhoGAM. Mechanism of action. RhoGAM attaches to D positive RBCs and covers them, hence prevents to present this to mother's immune system. Schedule. RhoGAM is given at 28 week and then at birth, that is within 72 hours of delivery. It is also given within 72 hours of sensitizing events like amniocentesis, abortion, etc. Dose is 50 microgram IM if given within 12 weeks of gestation. Full dose is 300 microgram IM given after 12 weeks of gestation. Treatment of RH disease or treatment of HDN. Treatment in pregnant mother. Plasma exchange reduces antibody titer in mother by 75%. Treatment in fetus. Intrauterine transfusion of blood to fetus is done if hematocrit is less than 30%. Treatment in newborn. Phototherapy, exchange transfusion, and IVIG are three important treatment options in newborn. Treatment options of HDN in newborn. Phototherapy is the first treatment of choice, for which 425 to 475 nanometer of blue or blue-green light is used, which causes photooxidation or photoisomerization of unconjugated bilirubin to soluble form. Exchange transfusion is done when bilirubin is critically high. It reduces bilirubin, improves hemoglobin, and also removes maternal antibody in the baby. For double volume exchange, 160 to 180 ml of preferably O negative fresh blood is taken, which must be cross-matched against maternal blood. Next is IV immunoglobulin, which is another alternative to exchange transfusion. It binds to Fc receptor of macrophage of reticuloendothelial system and hence prevents hemolysis. Thank you for watching this video. If you like this video, then hit the like button. Share this video maximum with friends and family. And subscribe to Pediatrics Simplified. This video is for educational purpose only. For medical advice, kindly consult your physician.